Welcome to Cobb and Company, the regular podcast of the Montague Cobb Institute. I'm Rolf Taylor, the producer and member of the hosting team, and I'm joined by my co-host today, Cobb Institute team member and early career biomedical student, Jasmyne Lott.
Thank you for the warm welcome, Rolf. Everyone, our guest today is Dr. Maisha Standifer. She is the Director of Population Health at the Satcher Health Leadership Institute at Morehouse School of Medicine. For over 15 years, Dr. Standifer has worked with various organizations to implement targeted strategies to address the impact of social detriments of health within vulnerable populations. Welcome to the podcast, Dr. Standifer, and thank you for coming here, taking the time out of your day to come speak with us.
Thank you for having me, and thank you for inviting me. Definitely, I'm excited to be here.
So during today's conversation, we're going to discuss two general areas. Firstly, we want to hear about Dr. Standifer's path to her current position as Director of Population Health at the Morehouse School of Medicine. And in addition, we're going to talk about how the Satcher Health Leadership Institute is leading a dynamic initiative that will address the structural barriers in HIV care impacting Black communities in the southern United States. Specifically, this project will focus on people living with HIV in Atlanta, Georgia, New Orleans, and Baton Rouge, Louisiana. As part of this initiative, Dr. Standifer is working at the forefront of addressing structural barriers that exist within those southern Black communities mentioned regarding HIV tests, treatment, and ongoing care. So we'll discuss this initiative specifically along with the related subjects such as the challenge of stigma, the essential need for culturally competent healthcare, and the lingering impacts of COVID-19 on all healthcare provision for the Black community. So I'm going to hand over to Jasmyne. As a potential future Cobb Scholar, I know she's very excited to hear about your career track and the specialization that you chose in medical anthropology.
Well, first, we would like to applaud the fact that Dr. Standifer is a Cobb Scholar alumna, which is the Cobb Institute's established program for helping healthcare team members, particularly those from minoritized backgrounds, to develop as research leaders and physician scientists so they have skills to research disparities and contribute to solutions. And it's very interesting to note that our namesake, Dr. Montague Cobb, Dr. Standifer has also built her career as training as a medical anthropologist with a doctorate from the University of South Florida, which I am attending now as well, so that's really cool to hear. Her master's degree is in public health, and in public health is from the Rolens School of Public Health at Emory University. These specializations have allowed her to apply unique insights within disparate and medically underserved population, and her continuing research focuses on the intersection between culture, health, and vulnerable communities. So let me start by asking you about your training as a medical anthropologist and your time as a Cobb Scholar. When did you first learn about W. Montague Cobb, and how did his leadership influence your choice of a doctorate and subsequent involvement with the Institute?
Well, thank you again, Jasmyne. I'm excited that you are attending the University of South Florida. Yay, yay, yay. Kudos to you. One of the best educational institutions, not only because, I will say so myself, brush off my shoulders, that I was able to obtain such a deep insight on applied anthropology, but also kind of setting and establishing that foundation for my love of community-based participatory research. I'll talk a little bit more about that. Again, uncovering my love again for finding out what's happening culturally, creating culturally responsive interventions to disparate conditions and illnesses in communities of color. We're calling them more medically underserved populations. Again, that institution, along with the Cobb Institute, solidified my passion for wanting to do more and go even beyond the realm of health equity, right? And so we'll talk a little bit about W. Montague Cobb. I did not learn about him in my graduate studies at all, which is not uncommon. However, once I learned about him after my didactic training in my applied anthropology program, I found that it not only, as I mentioned, said, aha, I am not alone There is a reason why, while I am pursuing community health interventions and how to reduce disparities, I now can solidify my passion in someone who's a renegade. He was a renegade, I would see, a scholar in anthropology, but also connecting anthropological methodologies within the medical paradigm. And again, trying to resolve disparate population health, right? So integrating all of that, what does that say? So again, as I go back into talking about W. Montague Cobb, it's a natural fit for me, right? And so when I learned about the Cobb Institute, found a little bit more about the founder, it was only natural for me to say, hey, yes, I want to be a scholar. I want to represent this particular institute throughout not only medical establishments, but within anthropology, because I did not learn about him in my scholarly and academic pursuit, and amplify what he did to all those, not just students of color, but everyone within the discipline. So I say this to say, I am so elated that I am representing Cobb Institute, I am representing W. Montague Cobb, and I'm representing all Black anthropologists to say, here we are, here I am, and this is who we need to pay homage to for being here and helping to create a better place for those who are underserved, voiceless. And again, we'll talk a little bit more about conducting interventions to dismantle, right, health inequities. And so, again, I'm excited that that is what the Cobb Institute does. When I was placed as a Cobb Scholar, it was indeed to do that, to be a representative for Cobb Institute and to make sure that me as I call myself a multidisciplinary scholar, an activist as well, and community leader that is able to go and sit amongst those who are medically underserved and be their voice for those marginalized populations. So it is a great honor for me to represent the Cobb Institute and be a Cobb Scholar.
Amazing. Thank you for your insight. I just have a few questions from my standpoint as a young person interested in the medical field. As a medical anthropologist and physician, what advice would you give to young people who are interested in possibly becoming a physician scientist and maybe even contributing to local communities and underserved populations? And more specifically, if you could go back into your part where you were first starting your journey, what advice would you give yourself?
Well, great. I'll start off with the first. I am a trained medical anthropologist and with a PhD as a researcher. I'm a PhD researcher, a trained anthropologist. So cultural anthropologist. So within the field of anthropology, you have several subdisciplines. And one of that is cultural anthropologist. And within that subfield, you have another subfield focusing on medical anthropology, health, wellness, and illness, taking into perspective of what are some cultural ramifications and some examinations that can be applied to, individuals who are suffering from diabetes in Southeast Mexico, right? What is occurring in the culture that we need to identify? Is it food? Is it lack of, physical activity? What's there? If we need to go and look at a population in Jamaica, right? What is actually happening when we talk about mental illness? Well, we need to really step back and say, what is the scope? What's happening with mental illness? How is it perceived by this population in this small country? Right? What is occurring? What's happening when you talk about the obesity epidemic that's happening throughout the Southeast United States, right? And so we need to really understand the perspectives of communities that are being impacted. We need to bring in policy. We need to bring in social behavioral scientists. We need to bring in clinicians and practitioners, right? So we're taking a holistic view and perspective of what do we need to do to apply education, inform these populations, and empower. Again, that is one of the key aspects of what I can do because I'm so diverse and well-informed of what's happening in the community. Then we need to make sure that it's just not a one-stop shop, that we need to provide empowerment messages, creating motivation, and again, providing information and education to populations. And that is what my role is as a medical anthropologist when I go into communities and train and inform members of the community. And I will talk about a little bit, stepping back, going back to your last question is, how did that kind of inform me in terms of my training when I was younger? What happened? And I believe Rolf asked me earlier where I'm from. I'm born and raised in Columbus, Ohio. So I am a Buckeye by birth. And I moved. So it's a great opportunity to get such a wealth of information in the Midwest, very diverse population, as I talk about, not just racial and ethnic, but also we talk about class as well. The exposures in education. As a Buckeye baby, living in Columbus, Ohio, I was very closely in proximity, but also affiliated with professors and students that attended the Ohio State University. Like I said, my parents were there. And so from early on, I participated in summer programs, starting in 5th grade, right? Going on through internship opportunities throughout high school and even took classes throughout undergraduate. So I was very, equipped to go directly into healthcare field, being a research scientist, working in labs, and of course, my love for the healthcare. Of course, I thought I was going to be a doctor. And I tell people, I attended Spelman College in Atlanta, Georgia, and being surrounded by women who looked like me, who thought like me, were in pursuit of being a doctor or a researcher was very, empowering, right? And elevating into what I need to be and how it can be accomplished. Also being taught by someone who looked like me. Very instrumental in terms of my development, that I can do anything that I put my mind to, particularly within this healthcare field. Ultimately switched over. I wouldn't say, grades might have dictated that switch from medical school, but my interest kind of went into, not just treatment, because that is what, doctors do. They treat. But how do I provide prevention messages, right? How do I conduct strategies and strategic alignment and research studies? And how do I really solve an issue, but help and create those steps to eliminate disparities, right? And so I was able to get training from Morehouse College, Morehouse School of Medicine early on, went on to pursue my master's in public health at Rollins School of Public Health at Emory University, and where I was trained by some of the best and brightest professors in class with great colleagues who I tend to still talk with today. Again, focusing on health disparities, right? Afterwards, I graduated and again, focusing on prevention. And in the space of Atlanta, Georgia, and right across the street was the Centers for Disease Control and Prevention. And that's where I continued to work for 10 years in the space as policy analyst, as a research fellow, as a biological health analyst as well. And in this time, I was able to see the intersections of policy. I would also talk about bureaucratic, established insight on what happens from a federal level, going down to implementation in state and local efforts of what's happening in public health departments and county health departments and even city health departments. And knowing that I can be an agent of change through some of these, I would say, requirements or some of these particular programs that were funded through federal and state and even county mandates. From working there, just to provide a little bit more insight, Jasmyne, 10 years, I started to get an itch. right? I said, oh, wow. I vowed to never go back to school. And so mid-career, after meeting a mentor who was a medical anthropologist at Centers for Disease Control and Prevention, she said, Maisha, I think you have an itch and you really want to be connected to the community. You should probably go into anthropology. And I said, anthropology? What is that? And I'm exploring, like, what is that? And I'm telling people, and they're like, oh, you want to go study dinosaurs? I'm like, no, that's archaeology. Let me go, go a little back and again, of course, demystifying what anthropology is. I went back and took, some additional courses in anthropology. And at that time, I said, okay, this is really what I want to do, and went more into the cultural side of health and health prevention. And I was advised to go into an applied program, not just a PhD theoretical program where it's theories, but I already had experience in implementing research studies. So they said, Maisha, why don't you go into an applied program where once you are placed within the program, you already have a head start on implementing strategies, programs, research studies that you can start off and go move full forward with some of the training that you obtain, whether it be in qualitative analysis, statistics, and quantitative analysis, right? In ethnographic study, right? And biological anthropology, linguistics. And that is all what I learned in terms of applying anthropology, conducting focus groups, right? Conducting interviews to really gain insight on the why individuals are suffering from, high hypertension at a disparate rate. Why individuals and how are individuals being diagnosed with cancer at a late stage? Why individuals don't have healthcare access if they're not able to speak English, right? If they're not able to obtain, a proper job that has benefits, so really understanding the why behind some of the health disparity stats that you see and uncover. And so I was able to work in communities focusing on barbershop education, right? And that was, again, educating barbers, including the community members, those who were staples in the community, to educate barbers on prostate cancer awareness. And while they're cutting those high-risk population who are African-American men, while they're cutting their hair, they're educating Black men on, hey, have you thought about going to get a PSA to check your prostate levels? Have you gone to the doctor? Why or why not? Right? And having those community agents who are leaders, staples, using those natural elements in the community to amplify what needs to be done. And that was where I kind of fell in love with being a community-based researcher and was able to really kind of solidify my space as a scholar, as an activist, and again, speaking for those who often don't get a front page in a newspaper or even at the faculty tables, able to speak to them. And so as you go back and talk about how I became a Cobb Scholar and understanding the value of Dr. Cobb, it is all because of my trajectory and my journey and all those who were before me, laying that groundwork to understand why I am here. And so it's just a great opportunity to continue to live the life that I ultimately was born into. Right. And so I'm glad that I am here to represent not only, again, Dr. Cobb, being there for Dr. Morgan, but representing the Cobb Institute and continuing to amplify all those things and create possibilities for you in the future, Dr. Lott, what is going to occur. So thank you so much.
Thank you so much. Those were so great points made. My favorite one was your reference to the barbershop. I feel like that is such a good way that we can educate others in their communities. Because it's one thing when you see a post on social media or see something on the TV saying, hey, you need to focus on your health and you need to educate yourself on these topics. But hearing it from someone who looks like you or someone in your same community just means so much more. And so I understand that you grew up around this. You grew up around being culturally competent,
Yeah.
competent, as you can say. What advice would you give to physicians on how they can become culturally competent if they are lacking in those ranges? And how can aspiring physicians address health disparities?
Well, I think it's great because I teach first-year medical school students. So this is what I embed in them from the start. Morehouse School of Medicine, of course, is on the forefront of training those communities of color, particularly the students of color who are aspiring physicians. And in terms of being culturally responsive, we call it responding to the needs of the community. Culturally competent is one level, but being responsive is very key. And that is what we create and embed in our students. It's creation of a curriculum. Morehouse School of Medicine is one of at least, I believe it's a few other programs that at medical schools that are throughout the nation that focuses on community health, placing first-year medical school students in the communities that they serve for a year for didactic teaching, where we again, I mentioned I go into Boys and Girls Club. We teach out of the Boys and Girls Club 1 day a week with my first year medical school student cohorts. And that last hour for 3 hours that we're there, that last hour, the medical school students have to create an engagement activity with the population that they're within, and they're connected to. So my medical school students that I teach have a cohort of teens that they have to engage with each week, whether it's talking about sexual health, whether it's talking about nutritional options, whether it's talking about future leadership roles, how to become a leader, how to become an entrepreneur. That is what we do. And so again, that is seeing what you can become, because those teens are now seeing, oh my gosh, this is maybe the first time I'm able to really see a future doctor, to see one that's in the making. And they can actually understand what it takes and the commitment it takes to become someone that's fully engaged, fully capable and competent, changing those that are around them, and hopefully being change agents within their own communities. And so we're excited that we've been able to conduct this program for at least, I believe, 30 years. And so again, we want to highlight that having it embedded in curriculum is key for medical schools. We know that shift in paradigm can be difficult, but what we do at Morehouse School of Medicine is embed it within the curriculum as we train and develop future healthcare professionals to talk and discuss and be agents for dismantling health inequities.
That's great. That's very important. Like you said, how it's embedded in the curriculum. Yes. I feel like this should be something in all medical schools
for
students, because it's not something that's just an option. This is really important, can really help to become more culturally competent and help to identify and eliminate health disparities in the healthcare field. So I feel like that is great, that what you're doing with the young medical students, and I'm glad that's something that is continuing to grow, hopefully, in all medical schools across the nation. Now, I wanted to point on something, how you said a little bit earlier, how you acknowledge the importance of mentorship, because, starting from as young people, we need a foundation somewhere. We need a little bit of help to get to our career and educational and overall personal goals. So what do you think are some of the good qualities of a mentee, and how can young professionals make the most of a mentorship?
Good qualities of a mentee. I would say the good qualities as the standard qualities I would believe as a mentee, and then I'll talk about a mentor, is the ability to be flexible, to be humble, and to be an active listener. Okay, there is a difference with just listening, to be an active listener. So my first things I talk about, to be humble, to be flexible, is that I think, and again, generationally, I know this change, right? And so I was a mentee, a young mentee like yourself, probably more than 20 years ago. So great opportunity to understand, because I was very flexible, amenable, able to shift and pivot when I said, oh, okay, and not be so hard on myself when I wanted to shift from being, a clinician or a doctor. And I said, oh, okay. Well, I'm an undergrad. I found that, okay, I don't think that's my passion. Again, I was third year and I'm like, oh, but I found out in my intro to public health class that I could still obtain additional training as a change agent, prevention specialist, as a social scientist. And so I was able to pivot. Okay, well, let me be flexible. Let me take more of public health courses. So I went over to Morehouse College and took Intro to Epidemiology, Introduction to Biostatistics. So this was a shift. I wasn't hard on myself because I am still learning and understanding. I was able to get an internship in undergrad at Centers for Disease Control. Right? If I wanted to pursue what I think I wanted to pursue, I was able to look for opportunities that were there. Step out. I didn't ask or look for someone to do it for me. Okay? Because I knew, and I asked questions. So when I talk about humility, being humble, ask questions, being flexible. If someone responds or does not respond, reach out to them again. Don't take it personal. We know everyone has lives. Everyone is busy. Don't take it personal. So all of that is encompassed when I'm talking about humility and being flexible and amenable to what your original goal was. But ultimately you can shift and say, oh, okay, well, let me check this out. I know because I remember having a mentor who stated, Maisha, you're able to just, kind of go with the flow and understand. I said, I know, because everyone has lives. Everyone has a life. Everyone has lives. And I understand that often where you start may not be where you end, or it may be a stopping point that you just need to recharge again and continue on. I learned that early on. So understanding that those are clear qualities that you have to have. I would say clear qualities that you have to have as a mentor, because I've had great ones and I've had, I would say not so great ones, but we'll say the great mentors that I did have. I will say they had an open door policy and they were able to communicate to me effectively. And I will highlight that this may not have been just via email. Communication was not just there via office hours, but I noticed mentors who I am still I still have a mentor relationship with for over 25 years, that I know that if I call them up from 25 years ago, they will pick up the phone and say, how are you, Maisha? How's it going? I know, they may or may not remember what they said, but as people say, you understand how people make you feel. How people make you feel. I remember that. And so I will talk about the great characteristics of a mentor is that having that open communication, whether it be, if they're busy, people may be busy throughout the week, but say, hey, when do you have time? When do you have time to connect, to talk, or to send me, opportunities that are there that may come across your table. And I've had mentors who, they've been busy abroad or on sabbatical, but maybe someone that was in Italy. I had one mentor advisor forward me an opportunity while he was on sabbatical in Italy writing a paper, but something came through his email and he thought of me. And he thought, oh, this will be a great opportunity for Maisha. And so you're thinking, wow, they took time out for me. So again, it's not just that immediate dialogue or the immediate, instant communication via email, but also those that I can text and say, hey, how are you? How's your family? And vice versa. I'm asked about that as well. So I think open communication professionally and personally is great, along with guidance when, you're not feeling well. you're not doing well. Everyone has low points in their life. I had a low point where my husband was ill, and I was going and entering a new job. And actually, I didn't think that I was going to take the job because, my loved one was ill. And I thought, okay, I need to tell, this person, my supervisor, that this opportunity is not going to work. I need to withdraw. And when I let that supervisor know, hey, I need to take care of my loved one. And they said, oh, okay, that is no problem. You're still going to take this job. You're going to take this job. And you're going to take all the time that you need with this new job to take care of your loved ones because I still need you here. And that, again, was the feeling of value, the feeling of this is a great relationship with an advisor and a mentor that understood where I was and understood where I can go. Those are key characteristics of a mentee and a mentor.
Thank you. I feel like the relationship between a mentee and their mentor is so important. It's such an amazing as it produces life-changing and new opportunities. So thank you for providing the qualities of each one. It was interesting to see the, certain qualities each one must have to foster a healthy and cooperative relationship. And I think that's all the questions that I have. We can now get into the actual, what we're supposed to talk about in this podcast, which is addressing the structural barriers in HIV care impacting Black communities in the Southern United States.
Thank you.
Thank you.
Really enjoyed that previous discussion. And Dr. Standifer, you're not the first person to say I hadn't heard about W. Montague Cobb.
Yes.
And which is a little bit remarkable in a way when you consider, he was in the White House making sure that Medicare went through.
Right.
He was in the White House making sure that Medicaid went through. He had such a big influence. And I hope that what this podcast can do over time is bring back those memories and just remind people that this is a really pivotal historical figure in the development of healthcare for everyone in the United States. So important. And just, on the subject of anthropology, it seems to me that anthropology is all about reality. And what you're describing is not the kind of academic or very medical model view of what's going on with people. It's what's really going on with people in terms of their health and understanding the reality, not the kind of abstract picture.
Yeah. Definitely. That's what it is. It's not theoretical. The theory is this, but we know people say, in theory, it works out like this. But when it's applied in life, we call it in the community, life be lifing, right? Life is life. We know that it looks different. Right. And so that is what real world experience is. Right. That's what we talk about, how we overcome obstacles, how we get beyond barriers, particularly when we're talking about in the healthcare field, beyond structural racism. Right? Beyond policies that have been enforced and established for generations. How do we get out of that? You talk about Medicare. We talk about Medicaid, right? We talk about historical factors. How do we, circumvent the issues and what has been established by redlining generations ago? So those are things that we have to know. No, it is not in theory. This is really what is happening. We are seeing the detrimental impacts of redlining to this day, and we'll see it beyond. So how do we unveil, restructure, after breaking that down, realign and rebuild, out of much of that? And that's why I'm here. And I think the value of anthropology is a necessity. That is why Dr. Cobb was such an instrumental force within the policy realm as well, in the creation, some of the leading agencies as you talk about, and also leading those future clinicians and practitioners within the NMA.
Right.
Mm-hmm.
And as you say, we can't fix these disparities until we acknowledge the reality of what has been happening historically for decades, for generations.
Yes.
This is kind of like the universal inheritance that we all have a responsibility to work with, I think.
Definitely.
So in the time that we have left, could you share with us an overview of the HIV initiative that you are part of leading? And if we run out of time, we're going to have a part 2 and we can get more into the details of it. But let's start with kind of an overview and the objectives of what you're working to achieve.
Excellent. Well, I'll talk a little bit starting off with the Satcher Health Leadership Institute at Morehouse School of Medicine, where we aim to be the leading and more the transformative force as we're connecting health equity and policy. Very key, because oftentimes policy is left out, but we know that policy is the driving factor for the social determinants of health that people are living in. As you talk about, Rolf, the reality factors, where you live, where you work, where you worship, where you play. Those are social determinants of health. So really, let's look at those political determinants of health as we talk about creating the policies, those legislative actions, requirements, and mandates that are established for generations, right? For centuries, and understanding what that has done. Once you understand what it has done, now you are more informed how to tackle, dismantle, demystify what has been done as we create a better and a healthier nation. And the namesake is after Dr. David Satcher. I don't know if many of you have heard of him, but he's a great servant leader, public health renegade, and the former, you could say, 16th U.S. Surgeon General in the United States under President Clinton. He was also the former director of the Centers for Disease Control and Prevention and the president of 3 historically Black institutions of medical colleges, Meharry Medical College, Morehouse School of Medicine, and Drew Medical College in Los Angeles. And so he created the Satcher Health Leadership Institute to train and inform future medical and public health leaders. Just on what we're talking about today, looking at the impacts of health disparities and the integration of policy and how to go forth and move the needle of health equity. And so I thought it very valuable to talk about that and setting that stage, Ralph, to understand what we are doing today when we're talking about HIV. With this particular initiative that we're focusing on is focused on eliminating the HIV epidemic. This is nothing new. The epidemic has been around for almost 40 years. And so many people who are listening may have been around 40 years ago in the 80s when it was a true epidemic, understanding what is going on, what's happening, unveiling all of that. Getting beyond stigma in the last 40 years has been a key. Circumventing administrations and structural factors that have placed some advancements on hold has been a key on while it continues now to be a factor 40 years later. And so as we talk about this effort, and this is a Gilead Sciences funded initiative, along with Xavier University in Baton Rouge, Louisiana, which is another historically Black college that trains pharmacists. Right? The next generation of pharmacists, while we're training the next generation of clinicians, PA, and public health professionals, they are as well. And so why not align our efforts when we're talking about eliminating this epidemic throughout the South? And we'll talk about this through the lens of a campaign we're calling Georgia Thrives. That's the newest initiative that's addressing some of the structural barriers in HIV care along that continuum throughout Black communities in Atlanta and throughout Georgia, in New Orleans and Baton Rouge, and throughout Louisiana. And so we wanted to make sure that we even highlight not just in urban areas, but throughout those rural parts, because that's often not really included that the sector, the geographic locations of rural area. And we know rural America has a number of disparities, not only economic, but we know that politically they've been kind of pushed aside. Also noting that is as a result, health disparities are relevant there along all class lines. And so we need to understand how high quality education and treatment options are needed when we're looking at HIV and AIDS. And so as we talk about kind of narrowing it down, Rolf, why we're here, we understood that post-COVID, then COVID-19 was an eye-opening and awakening agent for everyone throughout the world. So now everyone knows that there are health disparities. If you didn't know before, you know now. And you now know how the health industry impacts outcomes. And again, understanding how policy impacts health outcomes. You saw that where vaccinations, where access to vaccinations, you saw to care as well, what particular medications were given to what populations. Again, understanding that health and public health is very political. But when we really look at it through the lens of HIV and education, we understand with COVID, there was some disruption of services for those who were diagnosed, providing prevention for those who needed some efforts and some more prevention efforts there. And it also pushed aside some knowledge that we thought was there and allowed COVID-19 to come and take precedent over HIV. So now HIV is no longer considered, something that we need to think about. And we're under the, guise of health equity or sexual health. But we saw that there was some disruption there. And also there was started to be an increase in HIV, particularly in the South. And I'll highlight just in terms of Black males living in Georgia are over 6 times more likely to be diagnosed with HIV comparing to white males. And one of the most starking statistics that we understand that Black females living in Georgia are almost 12 times more likely to be diagnosed with HIV than white females. What is that saying as we talk about in the southern U.S., the HIV infection rate has been most prominent in Black men and women over the age of 13? What is happening? And that's when that anthropological knowledge assists in establishing and solidifying some steps, some legislation, and, some training efforts to be created. Right? As we don't just want to talk about, looking at prevention and treatment efforts. We need to educate clinicians, right? It's multi-pronged because clinicians also have stigma themselves. It doesn't, it's not eliminated once you go to school. We all know that who've been in school. Many of those stigma and many of the thoughts that you had and some ideologies that you had still stay with you. And if it's not embedded in the curriculum, as I told you, then oftentimes in those medical school places, you don't really understand and get the real life and real world expertise and that training. And so that's where we're assisting in creating modules, creating classes and courses on educating future public health professionals and medical school students, along with the pharmacy students. Currently, there's a class at Xavier that they've created focusing on ending the HIV epidemic in Black community. So when pharmacists go out, they'll be able to actively prescribe PrEP, that prevention mechanism, to those prioritized communities. We're getting beyond stigma, still there surrounding HIV and AIDS. Again, not just for clinicians, but we have branched out and we have started to have that bilateral connectivity and communication with policymakers. Policymakers still have stigma. And sometimes that agenda is there. So we have to let everyone across the aisle, both sides, understand the impact it has on population health, regardless of what affiliation you have to a party. everyone will be impacted. We need to talk about structural racism, how that is embedded in our public health infrastructure, in our medical paradigm, in the treatment regimen, right? So how is that embedded in the healthcare access individuals get, right? We need to connect the dots with connecting the increase of HIV in terms of transmission to employment options, to mental health, and looking at the increase in education when we're talking about sexual health across all facets and conditions. So we talk about maternal and child health, right? And so making sure we're not just siloing HIV, but it crosses all efforts when we're talking about cancer, the increase of certain cancers of those who are impacted by HIV. So it's not just unilateral, but we are making sure that we are normalizing much of the conversation that needs to happen and to empower. We're going back to that word, empower individuals to make healthy decisions when you're going out and, in terms of regular activity, taking it upon yourself to protect yourself and to protect others. And we know that there is some misconception that's there, and that is what we are assisted to do in terms of those three-pronged efforts that I highlight in terms of clinical, education, information, training, along with policy and informing and creating, again, those efforts as we talk about those networks to get beyond the stigma, right? And to educate. So we're excited that we're here.
Well, as you mentioned, the disparities are huge in terms of prevalence. And then there are also disparities in terms of representation within the healthcare workforce.
Yes. Mm-hmm.
So there's such a lot of work to do. There's such a lot of education to do. It's going to require huge and consistent engagement.
Yes.
So the big question is how? How do you do all of those things at scale?
So at scale, what we're doing, as I talk about, how do we do it? Well, we've established some steps, Rolf, in terms of creating curriculum. That's one step as we talk about creating the curriculum. There are few courses in medical schools that talk about HIV. What we do is that we're doing that, right? In the student population, in their courses, in residency programs, and training throughout grand rounds, right? So we have established steps that are solidified within medical schools and also medical systems. At Morehouse School of Medicine, as we're training residents, as we're training students, but then also in medical, the healthcare system that we have with Morehouse, training the doctors that are there. Again, we have older doctors that have been practicing since the onslaught of HIV. There have been many advances in treatment, right? We talk about PrEP. We need to educate doctors on PrEP. Educate the benefits of PEP and what can occur.
And then presumably,
so those are things that we're doing that, yes.
And presumably you also need to find a way to educate those less academic, public health oriented centers that need to be doing these things as well.
Yes. So that's what we're doing. Again, we're starting, of course, as we're talking about the clinical and the medical paradigm with those who are being trained and servicing the population who is most vulnerable. And that's what we're situated in the most vulnerable populations, right? And we're educating and servicing those who are in the most vulnerable populations. So as the clinicians are there educating their patients, we are also going out to the community centers. We're connecting with FQHCs, right? Those who are not able to have insurance access, but they're going to the health departments. In rural communities especially, we're going and educating and providing educational fora in churches, in barbershops, in beauty salons, in nail salons, in gym and fitness areas. So taking it to the communities that we are servicing and those that are surrounding us. Very key.
Dr. Standifer, I feel like we need another 2 hours to cover.
We do, just to talk about it. I'm excited to really, hopefully we can come back and really delve into some of the specific elements within our initiative as we talk about asset mapping, as we talk about data equity, as we talk and what Google has connected with us in terms of creating our health equity tracker, as we highlight data reporting and collecting data to better inform our policymakers, as well as we talk about educational webinars as well. So I'm able to come back whenever you're ready.
That'll be wonderful. I mean, you've provided a terrific checklist of things where we can take a deeper dive. And also, I think it's also a kind of a checklist for current Cobb scholars to look at and say, hey, these are areas that we could get involved in. These are all areas that we could be researching, documenting. There's a great opportunity to just go deeper with this.
Yes. And also get experience. Cobb scholars are welcome to become fellows of Satcher Health Leadership Institute. We have internship opportunities as well. So we welcome everyone, students to residents, to academicians and clinical providers to come and participate in this initiative.
So if you're not too busy next week, let's talk then.
We are. I'd love to come back.
And we'll do it as two parts.
Okay.
And we'll put this episode out next week, so that and then if we can do another recording as well next week, then we can split up a week later with part 2. That'd be great.
I'm ready to do it. Thank you.
Dr. Standifer, thank you so much for all that you've shared today. Any final questions from Jasmyne?
No, I think I asked a lot of more questions earlier today.
You did. Thank you.
Great discussion.
Thank you so much for taking
Looking forward to next week. Yeah, Nicole will set that up.
Next week.
Take care.
Thank you both.
Bye-bye.
Bye for now.
Bye-bye.
Okay, we got a lot done in an hour.